Thanks for having me. Hello to AMSA and everybody on the call. I am going to give a sort of a quick overview of my latest thoughts on where we really need to head in terms of a long-term solution for what most of us seem to, commonly refer to as a healthcare crisis. So the title, is a bit long and really not the best title, but I think the subject matter, on the other hand, is really interesting and really intriguing. And I hope for those of you who haven't necessarily kind of delved into this before, I hope thought-provoking. I was asked to speak about, really the ACA and sort of the future beyond the ACA and how it ties in with primary care. And what I might be doing intermittently during the presentation is bringing examples of what it means to me as a primary care pediatrician in the context of this healthcare crisis and why it is so relevant, not just to health policy buffs, but to actual practitioners of care, like myself. I mean, I see patients 5 days a week, and I've worked in the same community health center now for over 15 years and have very long and meaningful relationships with literally, hundreds of families. I have over 1,000 patients in my panel over many years and long relationships with my staff and the community in general. So, it definitely resonates. What I'm about to tell you resonates very much with me on a very daily basis. So I'm going to say advance because I don't have a way. Do I have a way to advance these slides? I think you have to advance them for me probably.
Yeah, I'll go ahead and advance them whenever you say.
Okay, go ahead. You can advance. Well, I'm gonna advance them on my end so I can keep moving here. So, so the next slide is just a quickie about disclosures. And I think the most important disclosure to make is that I am serving on a volunteer basis, of course, as the president of Physicians for a National Health Program. And I'm finishing my second year, actually. And I'll be finishing the second year as of December 31st. So it can be a 1 or 2 year term. And, I've been involved with Physicians for a National Health Program for over 10 years. I've got close to 13 now. And we're an organization that has now, boasts over 20,000 members, mostly physicians, but we have a very rapidly growing section of medical students. So we have these chapters called SNAP, or Students for a National Health Program. And probably many of you have a lot of crossover with that. I know there's a lot of connections with AMSA and with the Latin Medical Student Association and with numerous other organizations. So, but anyway, just my point is that those of us who are activists in single payer have really been doing this for years now, and we do it because we feel very strongly that our voice must be heard amongst so much fog that's out there in the general media and in other medical circles as well. Even within medical schools, there's really still today a dearth of clarity in terms of health policy. So I don't make any money by doing this, but I do have a great deal of satisfaction in this kind of advocacy work that I do. So next slide. So I'd like to be able to just very quickly go over some of the challenges that we face, and it's a broad range of issues that range from just the overall cost to things like access and quality, and of course touch on primary care. The second is that I'd like to spend some time really comparing the Affordable Care Act to single payer. Single payer is often referred to as expanded and improved Medicare for all. And then the last is to really dig in deep as to what it means when we say Medicare for all, what it means when we say single payer, what it means when we say national health insurance program, because a lot of people still are quite unclear as to what that truly means. Next slide. So are we truly the best healthcare system in the world? I think you can probably tell from the tone of my voice that we are not. The WHO, the World Health Organization, has and continues to do these report cards, and it looks at a number of different measures across the countries in the world. There's about 190 countries, I believe, that are part of the UN, and of that list, there's a group of about 30 that make up the Organization for Economic Cooperation and Development, which are the 30 richest countries in the world, and we really don't fare very well. We're not at the top of the list in terms of the developed world at all. Next slide. So, we have something called Medicare and Medicaid. It was established in 1965, and you can go to the next slide. Thank you. It was established in 1965. It just so happens it's the same year that Canada, not that far. The slide before that, uninsured all year is the one you want to get to. There you go. As it turns out, Canada established its Medicare in the same year, and you'll see a number of different comparisons to Canada, but we could compare the U.S. to a number of other countries, from Scotland to Taiwan to France, Germany, all across the world. And what you'll see is that we actually don't fare very well in a lot of health measures, and we certainly don't fare well in terms of our cost. But what you can see from this slide is that we're still today, even with passing the ACA and its full implementation, we're still looking at between 27 to 28 million Americans who don't have insurance, and then another about 31 million Americans who are underinsured. If you add those numbers up, we're still looking at around 60 million, or 1 in 5 Americans is really having a hard time accessing care, and when they can access care, they're having a really hard time actually being able to pay the bills that they're spent to cover the cost, all the cost sharing. Next slide. So in terms of total spending versus public spending, the very bottom part of the bottom bar graph, you can see U.S. and you can see yellow and you can see the orange or reddish area. And the most important part of this graph, this is per capita spending on healthcare across a number of different countries. And the most important thing to really focus on is the distance the yellow takes compared to the distance that every other country, with the one exception of Switzerland, but not by much, meaning that just in the public spending alone, we spend more money per capita than most countries spend total in terms of their total spending on healthcare. And then ironically, even though we spend so much more, we're close to $10,000 per capita, our health outcomes are not near as good as these countries who spend sometimes even half as much as we do. Next slide. You would think that we would have a significant growth of physicians over the year, and we have had growth. But what's really telling to me is that, over the last 45 years, we've had an enormous growth in managers and administrators. And I see that in my community health center even. We certainly see it in our hospitals. And to me, this is really telling, because what it shows us is that it's harder and harder for hospitals and providers of care to actually get paid for the work that we do provide. And it takes a lot of administrators to actually, work to get us reimbursement for the work that we provide. There's a lot of going back and forth, and it requires a lot of people to deal with so many different insurance companies, and every insurance company has its own set of rules and regulations and its own plan for how to avoid paying hospitals and doctors for the services we provide, and really for the sole reason that it's a good business plan for them. That private insurance companies are in the business of making profit. And so by taking premiums, whether they're through taxpayer or whether it's through private insurers, those premiums they really try to hold on to as hard as they can because that's where their profit's going to come from. Next slide. I'm going to go through a series of slides pretty quickly at this point here. I mentioned OECD, or the Organization for Economic Cooperation and Development, and so these are these top 30, wealthiest countries in the world, and these are the ones that we commonly kind of compare ourselves to in terms of life expectancy and a bunch of other things I'm going to show you. But just so we can really nail home the idea that the fact that the U.S. doesn't have the best health outcomes, even though we spend, in many cases, twice as much as other countries on health expenditures. So we don't live the longest. Next slide. I threw this one in because, well, I am a child, I'm a children's doctor, I'm a pediatrician, and so I'm always thinking about children. And from a public health hat, Malika mentioned my master in public health, from a public health angle, one of the things that we really strive to in public health is to focus on the populations that are most vulnerable first. And children are one of those populations, as are the elderly. So, as are people with disabilities, as are people who are living in communities with, enormous unemployment, people of color. So, we really try to focus on subpopulations that are the most vulnerable. And so you would think then that, being one of the most vulnerable populations, that is children, that we would focus, very, intensely on them, and we would make sure that they don't live in poverty. And you can see in the U.S., we're not doing very well with that. We're actually not so far away from Mexico, which is not considered one of those top 30 richest countries in the world. Next slide. We certainly don't have the lowest infant mortality. And of course, as you go from state to state, you'll see a variance in it, but this is very telling that we don't have the lowest. Japan is not on this slide, but just so you know, Japan is also, I think, even lower than, it's not lower than Sweden. I believe it is, but it's very, very, very low. And they spend a fraction of what we spend on healthcare. Next slide. Maternal mortality, similar trend. We really don't do the best in maternal mortality. Next slide. Oftentimes you'll hear people say that, well, the reason why our healthcare is so expensive is because of behavior. People are smoking, they're doing drugs, they're taking a lot of risk, and they're involved in risky behaviors. And so smoking is one of the most common ones people bring up. But in fact, when you look at the prevalence of smoking, what you'll notice is that we're not the highest. There was a time when we had 25% of our adult population or more, not that long ago, who smoked. And we've really reduced that dramatically, but clearly, we are not the worst in our behavior, yet we're still having poor outcomes and lots of money we spend. Next slide. Some will claim that, well, it's costly to provide care because we have, a disproportionate number of elderly. As you can see, clearly that's not the problem when you compare to other countries. Next slide. Some will claim that, it's expensive here in this country because, we provide a lot of inpatient care per capita. Once again, we're not at the top of the list. We're not keeping them in the hospital for, exceedingly longer stays. There are many times when you probably should stay in the hospital a little bit longer than you do to receive appropriate care before you go home, before you rely entirely on your own family structure or networks at home. You often need to have that kind of backup before you go. So we're not keeping you longer. Next slide. Some will tell us that, well, we are overutilizers and that we go and see the doctor, far too many times a year. And the truth is, this number hasn't budged very much for us. If you go to the next slide, the number hasn't budged very much for us even since 1965. When Medicare was passed, we had about 4.7 visits physician visits per person per year. And it really hasn't changed very much. We're actually still, this is from 2015 OECD data, and we're still at 4. And Japan is fortunately on this next slide. I'm not sure why your slides aren't advancing, but hopefully they will soon. But what's interesting about Japan, and for those of you who haven't seen Sick Around the World, I do recommend it. It's a quick documentary to look at how other countries are doing in terms of access, in terms of cost. And Japan is one of the countries where the documentary films and speaks to physicians and patients. And, you know, one of the things about Japan, and you'll see it eventually when your slide comes up, is that, you know, we have an average of about, you know, 12.9 or almost 13 visits a year. And this is a pretty impressive number. I mean, we're talking, obviously you can do the math, but, you know, there's 12 months in a year. So, you know, the average Japanese might see the doctor at least once a month. And you might think on you know, the sort of first glance that that's a bit excessive. But I can tell you from, you know, seeing a lot of high-risk patients that, you know, who have, you know, moderate persistent asthma with obesity and metabolic syndrome and, you know, pre-diabetes, all these things that, you know, once a month actually is sometimes not even enough. And these visits with me can be very quick, but they're necessary visits. And if my patients who are primarily depending on Medicaid to cover the bill to see me, if they had any kind of copay or any kind of you know, financial disincentive to see me, they wouldn't see me. And I can guarantee you, from having been doing this work for over a decade now, that they end up in the emergency room, you know, if they don't see me, or they end up, you know, eventually with diabetes. So, you know, it's actually quite reasonable when I think about this slide that, you know, in my practice, in my own practice and all my colleagues, you know, we often see patients, you know, once a month, and these are for, you know, chronic disease management. And it is necessary. And I think that if you're talking about primary care for a you know, a much higher income population that has, you know, much more access to resources in general, access to mental health resources, access to nutritionists and dietitians and physical therapists for their children who, you know, are involved in high impact sports and on and on. You know, you wouldn't necessarily need to see me once a month. And some of them still do. Some of them have other chronic diseases. No matter what your income level, they need to see, you know, their primary care. And if you add up the specialists with that, it can be very easily up to that number. So we're really quite below in terms of our utilization. And even despite that, we're still, as I mentioned earlier, are spending far more money in total health expenditures. Next slide.
We did have, oh, sorry, I just wanted to say we did have one question about this graph. Someone wanted to know, is this adults and children or just adults?
And are you asking about the physician visits?
Yes.
The physician. I don't have that actual reference, the details of that reference in front of me. I do believe it's for all ages. But if you remind me, Malika, I can look into that and make sure I get that for you. That's not a problem. We can get that question answered. You'll notice there's a source for every one of these slides. And one of the things about Physicians for a National Health Program is that we're very, very much data-driven. And so everything you're seeing up here is going to be from a peer-reviewed journal or a very reputable source, a source that anybody would agree is a reasonable place to go to find information like this. So just to throw that out there, people know that. Some will say that we spend so much money on nurses. I put this up here to just remind us that we don't have more nurses, you know, per 1,000 population than any other country in the world. Next slide. What we do know in terms of out-of-pocket payments is that, and this has been worsening, not improving, even with ACA. You know, we've got at least 25% of people who have been able to purchase insurance on the exchanges with the ACA. 25% of them, you know, have deductibles of more than $2,500, which is an enormous amount of money for somebody who is in the situation that they are in to be a candidate for buying insurance on the exchange in the first place. So the out-of-pocket payments are extraordinarily high in this country as compared with any other country. Next slide. And on the insurance side of things, you know, this is where I find this fascinating that, you know, when you look at the data, you know, and then you look at public opinion, there's sort of a disconnect here because, you know, I mentioned earlier, you know, the insurance, the for-profit insurance companies, you know, they are charged with making profit, and you know, they have shareholders, and so they're doing very well in their business plan, which is to create lots of profit. And you know, for every dollar that we hand over to insurance companies in general for premiums, we pay premiums every year, every month, excuse me. For every dollar that we give them, you know, only 88 cents on that dollar actually goes to providing care. So that's an enormous amount of overhead, you know, 12%. And if you compare that, for example, to a non-profit health insurance company, and the biggest example of that would be Medicare as in its current state, you know, we see an overhead of less than 3%. In Canada, you'll see an overhead of, you know, 1.8%, even lower. And you'll see those same very, you know, similar figures pan out for countries like Taiwan. Taiwan established their single-payer healthcare system, I believe, in 1995. You'll see the same, very similar number in Scotland. So it's the way in which you can save, you know, literally $400 to $500 billion, and I mean billion, not million, $billion a year, by removing this middleman, this private insurance companies entirely from the picture, and really having one public fund through which we can pay the private delivery of care. Next slide. This is based on a fairly recent look at the administrative costs to hospitals, specifically hospitals. And this is very telling, once again, when you have, you know, 25% of an average hospital's budget going to administrative, just administrative costs, just trying once again to get paid for the work that they do. And when you compare that to other countries, you know, they're spending half of what we spend just to get paid, right? And it makes sense if you go to these countries I mentioned, if you go to Scotland, if you go to Canada, if you go to Taiwan, you know, everything is electronic as it is here in general, and they just send the bills to one place, and that's the government. Now, the government might subcontract with insurance companies to do the billing for them, but it's still done through a public fund and a public system whose main goal is not to create profit, but whose main goal is actually to provide people with care. Next slide. Similar idea here, but looking at a percent of the GDP. And these may not look like a lot of numbers to you here, from 0.98 to 1.5, but this is a precipitous rise in the percent of the GDP since 2000, 2015. And this is really, really frightening to watch this go up. Next slide. So I hope I'm really kind of, you know, sending home this message that's based on the data, that's looking at how difficult it is for people who are trying to deliver care to actually get paid for the work that they do in the current model. You know, just today I was seeing a patient, and I saw them on Monday, and they had a wrist fracture, a closed wrist fracture. And the mother already had an orthopedic surgery appointment that was scheduled for today. And I said, you know, not a problem. I took all the splint off, looked at his wrist, looked at his arm, did a neurovascular exam, make sure there was no pressure ulcers, et cetera. And, you know, I was pretty comfortable with, you know, there was no more significant swelling. So he's in good condition, clinical condition, to have his wrist casted. So he does need to see the orthopedic surgeon today. And as it turns out, in most of the country, in almost every state, Medicaid has been privatized, just as Medicare has been privatized. And this patient of mine has a for-profit private insurance company for his Medicaid plan. And remember, Medicaid is paid for by taxes as well. So we have a for-profit company. And it just so turns out that their system for us to be able to authorize the referral that I made on Monday was down, and it's been down since Monday. So here I have a situation where I have a child who needs clinically to see his orthopedic surgeon today to get casted, and I can't get him the referral for the orthopedic surgeon to see him today merely because the insurance company that's supposed to be providing him with quality insurance, paid through taxpayer money, doesn't have the technological system for us as of yesterday and the day before and today for us to allow us to get it authorized. So I'm delaying care, not because I made the wrong decision clinically, not because his mother didn't bring him in, but only because there is a snafu in the technical system within the Medicaid company. And, you have to ask yourself, is this just an accident? Is this just an accident? And I like to think that this is an accident. I'd like to think this is not planned. But we have to be realistic here. When you take this case I saw today and you multiply that times millions of cases across the country every day, what you start to wonder is there actually a plan to deny care? And if you talk to other primary care physicians, if you talk to the specialists, if you talk to patients, it's not possible that all of this is just mere accidents. And remember what I said earlier, when you look at the profit margins and you look at the goal, the actual mission of private insurance, it's not to provide care, because the more care that they actually pay for, the less they get to keep for their profit margin. So it really makes me wonder, and this has not happened even just to me, an isolated incident. This happens all the time. And our hands are tied. Like, there's nothing I can do. I can't make the orthopedic surgeon see my patient without insurance. I did try. We called over there. I wrote on the unauthorized referral, please see them today. It'll likely get authorized, and you'll likely get paid if you see him today. But this is the situation we currently work in. Next slide. Oftentimes there's people wonder, what would happen if we had single payer national health insurance in terms of physician salaries. And, if you're on this call through AMSA, or if you're involved in SNAP or any number of organizations, I have a hunch that, you didn't go into medicine to make, really high salaries. I certainly don't make these kinds of numbers. I mean, these are Canadian dollars. And the Canadian dollar isn't as strong as it once was. But I can tell you, even from my own personal experience, that, if I were to practice pediatrics in Canada, I would probably make twice as much as I make right now. And this example, you see again and again throughout the country, throughout the world, when you compare physician salaries here with physician salaries in other countries, especially in primary care. But you see on the list here, even the specialists fare rather well. And they do fare better than the primary care. I love what I do, and I would never give up my job to be a specialist. I respect the specialist. I need the specialist, but I love what I do. But if there's any concern that you would live an impoverished life because of single payer, it's simply not the case. It's simply not true. Next slide. I give a lot of talks on the importance of being out in nature and being able to clear your mind. So I grabbed this slide actually from a physician colleague of mine. He's actually an activist, single-payer activist in California, part of the California chapter, and he's quite a phenomenal photographer. Anybody who knows Jeff Key, that's who that is. Next slide, yeah. So let's dive into a little bit into what is the ACA. People wonder what it is. And, it was passed in 2010. And go to the next slide here, which is more readable. So there are, 10 essential benefits. There's no standard benefit package. And you can see the things that I wrote down there in smaller print. I'm not going to read them out to you. And in terms of preventative services, and this I've noticed even with my own kid who goes in for myself, but, for well child exams, there are now no more co-pays and deductibles for that, and that's fabulous. I mean, this is something actually we should really be proud of. The next thing is that ACA was meant to limit insurance overhead, but unfortunately, we have one of the strongest lobbying in from the healthcare industry, and far stronger than amazingly far stronger. Much more money is spent on the healthcare industry lobbying than a number of other industries. out there, and it really has weakened its enforcement. And one of the things that I bring up all the time is this whole issue of underinsurance. Because here we have 20 more million Americans who have an insurance card in their pocket, but still today, if you're an adult, you're an adult and you're less than 65 years old, a quarter of you are going to have a difficulty in just paying the copays, and a quarter of you will very likely make some decisions not to see a doctor because you can't afford to see them. So the lack of regulation in terms of the premiums, deductibles, and copays for everything else, the non-preventive services, is a huge impediment for people to get care. And so we see people, postponing care or just, not getting it, ever not getting it, because they're too worried about the bill. They can't pay the bill. And then lastly, there are these out-of-pocket caps, but as I mentioned earlier, they're extraordinarily large sums of money for people who are really some of the lowest earners in the country. So I'll give you an example for myself even. There won't be any issue with confidentiality because I'm consenting myself to tell you this. But I had a Baker's cyst in my right knee that ruptured a few months ago, the end of May. And I had no idea what that, was going to be like, obviously, and nothing that I did to, I wasn't engaging in any high-risk behavior. I was actually walking in my kitchen, and I pivoted to turn around and probably tore a little bit of one of my ligaments, and that probably prompted the cyst to burst. And within 3 days, I was entirely handicapped. I couldn't walk. I couldn't bear weight. So I did the appropriate things. I went to my doctor. I had a sonogram done. Then I needed to get an MRI done. And they were actually all rather appropriate. Engaged in physical therapy, had a number of visits for that. Went and saw a physical medicine and rehab doc who eventually had to inject my joint, all of this. And, I'm supposed to have one of the best insurance available. I'm on my wife's plan, and it's a federally employee benefit plan. And I still ended up paying, close to $1,000 in copays after it's all said and done. And that's on top of all the premiums that we already pay. And that's just extraordinary, right? And I can afford it. I can't afford it. But I think about, people who are just, one step above income of my patients who have so-called private insurance. And I have some patients with private insurance, and they cannot afford that. So, it's just a reminder to me, how incredibly difficult it is for people to be able to just psychologically get over this. They really can't afford to pay what's expected of them in order for them to receive appropriate care. It's really interesting if you think about, people who get diagnosed with cancer, these or are in a terrible accident and are disabled and have these sort of life-changing events in their health. And, I often think, what would it be like if you had those same life-changing events that happen all over the world, yet you don't need to worry about the medical bill. And what I find, happening in my friends and my colleagues and my patients all the time is that, they, as soon as they can sort of get over the shock of their new diagnosis, the first thing they think about after that is, oh my God, can I afford to pay for these medical bills? And that's a travesty. We should not be living in a country as rich as we are and have to have that be our second thought after we sort of grapple with the diagnosis in the first place. So next slide, back to the impact on the uninsured. So I mentioned earlier, we have had a significant decrease. We're down to about 28 million now. The slide points out the difference between 2010 and 2014. We have had significant expansion in Medicaid, and that's the bulk of as you can see here, the bulk of the numbers and millions that did get insurance got it through the expansion of Medicaid. And this is still despite 19 states still today opting out. So those governors of those states have decided to not accept that kind of federal funding, and it's very, very generous federal funding. So this is mostly based on their unwillingness and to philosophically to say, we're going to expand this in our state. And the people who are most hurt by that, as you probably suspect, are people of color, people who are low income, obviously, people who really have nowhere else to go and have otherwise no other likely source of care they're going to be able to get. Individual coverage has had some impact. We see about 4 million through the exchanges. I believe it was just last summer there was an important Supreme Court decision that allowed people living in states whose governors and legislators chose not to establish an exchange for them to be able to purchase the exchange insurance through the federal exchange. That's an important decision that, still allows people in those states to do that. And then for those of you interested in how its impact on children, I kind of throw in this children piece here, pediatric piece. We had a significant reduction from 7.5 to 4.8, but that's still nearly 5 million children. And I find that, sort of still today just very hard to swallow, to go to bed at night thinking that we still have that many children who are uninsured. I mean, that's a really sad sign that we perhaps don't live in the most civilized country in the world when we allow this to happen. Some people have suggested that we take Medicare and we, in deciles, as 55 to 65, add that group to Medicare, then go down to 45. I'd say start with the children and go up. I mean, they're the most vulnerable. And frankly, they're the most to benefit from this. And this is just my opinion. This is not a PNHP, but it is quite depressing to think that we still have that many children without insurance and without access. Next slide. I mentioned earlier, that we have a serious problem with underinsurance. It's really the new insurance is underinsurance. The ACA really well symbolizes what we're doing today is we're giving people an insurance card in their wallet, which is better than not having one, but really what it represents is underinsurance. And these are folks that simply can't pay the bills. They don't go see a doctor. They don't get a test that the doctor told them to get. They don't get prescriptions filled simply because they can't afford it. And they have insurance. And we even see this with Medicaid now. This is, a growing phenomenon in Medicaid. I saw a patient the other day who needed to had a anaphylactic reaction to peanut and needs to have an EpiPen. And the EpiPen he had, I believe, was expired. So I wrote the script and sent it to the pharmacy, and the parent came back and said they couldn't afford it. It wasn't covered, so they couldn't afford it. And I said, what do you mean it's not covered? This is a life-threatening condition, and it's a life-saving medication, and it must be covered. So I know you all are probably somewhat familiar with this case, this company, Mylan, who manufactures the EpiPen, which is an injectable form. It's a pre-filled syringe that's self-injectable. And I like to remind myself if these slides are actually true or not. So I got on the phone that day, and I told the dad, let's just get on right now with the insurance company, with your private for-profit Medicaid right now, and let's get this fixed. I'm sure that we can get this fixed right now. This is crazy. So I got on the phone. I was on the phone for about 45 minutes, and I went from person to person, explaining to them, why this needs to be changed. And I don't fault any of those individuals because they're powerless. But, whom I do fault, would be the insurance companies and the pharmaceutical companies who are making it more and more difficult for people like me trying to provide doing the most simple of tasks every day, writing a prescription and getting it filled in order to save a person's life. Next slide. One of the most interesting things to me is this issue of medical bankruptcy. And, it's fascinating because we have, about 1 million bankruptcies that are filed every year. And, I don't know if you all are watching the debates and, all this talk currently about, one of the presidential candidates, Donald Trump, who apparently filed for bankruptcy many years ago. And if you look at these million bankruptcies, more than half of them are because people can't pay their medical bills, so they end up losing their home and they end up losing any kind of accumulation of wealth they had, and they file for bankruptcy. That is horrible, but I think what is most interesting about this is that all these over 500,000 medical bankruptcies, as we call them, 75% of them had insurance at the time they became ill. So what that tells you goes back to this issue of underinsurance. We think that we're protected because we have an insurance card in our wallet. We think we're safe from losing our home and losing our lives because we have an insurance card in our wallet. But the truth is, if you look at the fine print on almost anybody's insurance card, there's too many holes in it. So it's not real coverage. And this is not the case when you go across the border to Canada. This is not the case if you go to almost any of the other 29 richest countries in the world. People don't claim medical bankruptcy. They don't claim bankruptcy because they can't pay their medical bills. And even with the passage of ACA, there's been no significant change in the number of the medically bankrupt. Next slide. So just to remind you, back in 2010, there was a lot, or actually 2008 and 9, there was a lot of talk about all these proposed cost control provisions within the ACA. And I just want to remind you as we go to the next slide that of all these proposed cost provisions, this slide is blank for a reason. So of all those cost control provisions that were claimed to be so important, this is how many of them were actually proven to work. So it's blank because none of them had been proven to work before they proposed them. So there was a lot of talk based on absolutely zero data, solid data. And as future doctors, I'm sure that you always want to make a recommendation when possible based on the best evidence available. It's amazing to me that we would throw out these kinds of cost control provisions as a way to save billions of dollars when in fact none of them were proven. And the one that is proven to work, you probably guess what that is, Singlepayer. Go to the next slide, please. Actually, 2 slides ahead. I've mentioned to you what underinsurance looks like. And just to remind you once again, when we were talking in 2008 and 2009 leading up to the passage of ACA, everything was about universal health care, universal health care. We're going to take these 50 million, these 47 million uninsured Americans, and we're going to eliminate uninsurance, and everybody's going to have insurance, everybody's going to have access. Well, that's not what happened. What happened is what you see in front of you is these tiered systems. And, if you have a little bit more money, you can get the platinum. If you have a little less money, you can get the bronze. And you're going to have higher co-pays, more cost sharing. This is what's happened. So now, as I mentioned earlier, the ACA really, it's basically this new underinsurance is the new norm. That's what we've created right now. And that's not what we were talking about. It's not the solution to uninsurance, is to create underinsurance. Next slide. Just to give you an example of what it looks like in one state in terms of these kinds of cost sharing that go on now in terms of what you might purchase through a bronze plan through the exchange. These are not families that can afford a $6,000 deductible. I'm just, I think this is common sense. If you think about the kind of person who would be purchasing this in the first place, this is not the kind of co-pays and cost sharing they can do. An out-of-pocket maximum of $12,000 is enormous for anyone. It would be enormous for me. I wouldn't be able to afford that. Next slide. Next slide. So just to quickly summarize the ACA, because we could talk probably for hours about the ACA, is that the ACA for me, it certainly has some good, important changes, like the expansion of Medicaid. And despite the fact that 19 states chose not to expand it, it has provided access to health care that was otherwise not available before ACA was passed. It has reduced the number of underinsured. That is important. You know, so we don't want to understate that. But at the end of the day, you know, what those of us are, you know, who are single payer activists are trying to make sure people are reminded of is that the ACA is not the path to single payer. If you listen to the vice presidential debate last night, those words, single payer was actually said. Those words were uttered during the debate, and that tells you something that we're definitely being heard now, which is very good. But you know what was said on the debate last night was that ACA is a path to single payer. You've heard that probably many times. And if you look at the differences between them, you clearly understand that it's not, because ACA relies on private insurance. You might want to go to the next slide. People can have a little visual with this. But the real issue is here that we're relying on private insurance, whether it's through the private insurance of Medicaid, the private insurance of Medicare, whether it's through the exchanges. We're relying on the for-profit, profit-driven model of private insurance to expand insurance to people. And that model is faulty. And that is really the essence of why healthcare is still unaffordable. It's why people are claiming bankruptcy. It's why the country sees a greater and greater percent of its GDP being spent on healthcare, up to about 18% now. It's why you see the overall hospital administration at 25, hospital administration percentage of the budget at 25% and increasing. The reason you see all of this, its basic premise is because we're relying more on for-profit private health insurance. So if I could get that one message really, really clear, that is the path we need to stop taking. We cannot keep going down that road. Next slide. You may or may not know, keep going, one more slide, about public opinion. There was even a recent Gallup poll in 2015, much more recent than this. I keep this slide here because I find it fascinating that the public opinion hasn't really, you know, changed very much in terms of its support for universal health care through single payer, through a publicly funded system. And it's still true today, that most Americans, when asked the question of whether they would like to keep their current plan or would they be willing to transition to a system like Medicare and expand it for everybody, and the public opinion is there. Next slide. Keep going, because I really want to get to single payer in a second here. So just jump forward to single payer, a national health program for the U.S. These slides will be made available to you, I'm sure, so you can look over them at your own leisure. Actually, stop there for a second. So support for government legislation to establish NHI. This is a kind of an important study because it was the first study that looked at, it was quite a large survey study, and it was done by Erin Karol, actually a fellow pediatrician, and Dr. Ackerman. And it was done in 2002, 2007, so it was repeated, looking at any change in the opinions of doctors. And there were 13 specialties that were asked these questions. And the most important, the question that was asked was whether they would support the establishment of a national health insurance program. And you can see on this graph that the vast majority of the doctors, so more than 50% of the doctors, support establishing, this is just within the physician group, support establishing national health insurance. There were 3 subspecialties, radiology, anesthesiology, and some of the surgical subspecialties that didn't have a majority, but every other one did. Even general surgeons do. So I think that, you know, this is very indicative of, I think, a lot of the burnout that we see among doctors, especially, you know, young doctors. You would think it would be the other way around, but I'm seeing sort of this, you know, in my practice, we have a lot of junior doctors, and you know, I guess I'm getting older, so I'm one of the more mid to late career now. But you know, I see this frustration in them because, you know, here they are, they're just so excited. They just finished medical school, just finished their residency, and now they're actually practicing. And you know, even today, you know, my friend and colleague next to me, who's a med peds doctor, you know, says to me that he still has this patient. He had him 3 or 4 weeks ago with the same problem, and he's got stage 4, he's got a colon cancer, and he can't get him to see the specialist, he can't get him his chemotherapy, he can't get him what he needs to try to beat this cancer. And he even used the words today. He even said, this is an alliance patient, meaning we have a not so wonderful insurance called Alliance that just doesn't have what we need. It doesn't have the formulary that we need to cover our patients. It doesn't have the access to specialists that we need to cover them. And it's a sad day when we refer to our patients as by their insurance company. What's next? Are we going to say, oh, that's an Aetna? You hear this all the time, actually. When you rotate to the hospitals and you rotate to the clinics, oh, he's an Aetna patient, or he's a Cigna patient. And we've started to categorize our patients in terms of their insurance companies because it so strongly dictates what we can and can't do with them, rather than allowing us to practice medicine in the way we're supposed to and actually treat them the way we're supposed to. We're forced, literally, to provide them with substandard care. Next slide. So keep going. Keep going. One more slide. So there's 4 basic principles to single payer. We have to make things simple to remember. And I know you know this because you're all in med school, right? So if you ask somebody to remember 10 things, it's less likely than to remember 3 or 4 things. So, there's just these magic numbers to remember them. And, it is pretty straightforward. One is that, we all need to agree that there are human rights and inalienable rights, and one of them is access to comprehensive care. For those of you who know what the public health model of social determinants and physical and social determinants of health are, healthcare is one of many pieces around us and within our lives, the context of where we live, that determines, whether we're going to have a healthy or unhealthy life, how long we're going to live, et cetera. But an essential feature for us, especially as doctors, is you've got to have access to care, so it has to be a human right. The second is that, we have to have a sense of autonomy. So, we should be able to choose, where we're going to seek care, which hospital we're going to go to, which pharmacy, which medical supply company, et cetera. And the truth is, with our current system, you don't have that. You don't have that autonomy. You don't have that choice to go where you want to go. You go where your insurance company allows you to go, and that may be nowhere. Sometimes there just simply is. They don't have that benefit on the plan, or if they do, it could be hundreds of miles away. And that we've also seen is a growing problem with the exchanges, is that they just don't cover much. And what they do cover, sometimes people can't get to because they're literally hundreds of miles away. The third is this issue of profit and personal fortune. And, that's different from a decent salary. No one here is saying you shouldn't have a decent salary. And I showed you that slide of salaries, comparable salaries in Canada, just across the border. And the same is true for, for every other developed country. The doctors did fare fine. But what I'm talking about here is when we have CEOs of insurance companies and CEOs of pharmaceutical companies raking in, literally like dozens of millions of dollars a year. I mean, some of these folks make $100,000 a day. This has got to stop. I mean, this is a lot of the problem is that, you look at the disparity between the CEO of an insurance company and the person answering the phone the other day for me who couldn't tell me why I couldn't prescribe a life-saving medication for my patient. That gap is growing and growing and growing. And the fourth is, if you believe in democracy, and I happen to believe in democracy still, the public, not the private insurance companies, not the board members, not these backroom conversations, the public should set the overall health policies. That's what we're getting at here, is that, if we have problems with weight, to get elective procedures done, if we have problems, covering certain medications, that needs to be part of a public debate. And it is, in fact, when you go to the other countries around the world that have some form of national health insurance, which is why you hear about it. You don't hear about these weights on our end so much because, well, if you're uninsured, the weight is indefinite. But if you're insured and there's a weight, right, it's not in the public domain. You don't get to hear about it. And if you have a complaint about it, there's little you can do here because it's not a democracy in this case. You don't have a say. They just tell you no, and no is no. Next slide. So to be clear about what this guarantees, I just mentioned earlier, comprehensive care, quality care, choice, and affordability. And we really don't have any of these things right now. I shouldn't say any of them. It depends on, the quality depends on where you seek the care and also, you know, what you're able to afford. So single payer national health insurance is simple, and I think the simplicity of it is why it's so affordable for the country and for the individuals. Next slide. You know, there's a bill in Congress. It's been reintroduced for over 10 years now. It's called HR House Resolution 676, and it's a fabulous bill. It is authored by and introduced every year by John Conyers, who's a Democrat from the state of Michigan. And it's important for you to read. It's, you know, compared to 1,200 pages of ACA, the bill I just referred to is 11 pages. And I've read it, and I encourage you to read it. I think it really makes sense for you to spend the time to read it because it very clearly and succinctly shows you there's a legislative role and a legislative model for how to make this happen. Next slide. For those of you who are business-minded, and I think you do need to be business-minded, you need to have a business plan, especially if you're thinking about having your own practice or joining a practice. You need to know how you're going to keep the bills, the electricity paid. You're going to have to know how to pay your staff. You're going to have to pay their health insurance if we're in this current system. You got to have a business plan, and these are generally the accepted, you know, business models for how you get paid: fee-for-service, a salary, or a capitation payment to the HMOs, and all are reasonable. You know, I might have one that I prefer more than another. I happen to be salaried, so I sort of prefer that model personally. But, you know, we're venturing now into this world of pay-for-performance and bonuses for doing the things that I think we should be doing in the first place. So, you know, I personally would like not to go down that route. I would like to go down the route, you know, where you're a salaried physician. We'll reduce a lot of these barriers to care, a lot of the frustrations by having a much, much more simplified system in which we can get paid for the services we provide. Next slide. And going back to the ACA and single payer, you know, this is not rocket science. And I have a couple of friends who are actually, you know, astrophysicists, and they say they're actually not rocket scientists because they're astrophysicists. So rocket science is a little too simple for them. But for the, you know, simple-minded physicians and future physicians that, you know, we are, rocket science is a bit complicated. But you look at this, and you say to yourself, you know, compare these two things. You know, what is it that we want? You know, and on the left side, it's yes, 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 yes. And on the right side, it's no, 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 no. I mean, it's not that complicated if you really want to look at it in terms of the things that we were talking about prior to the passage of ACA, the things we've been talking about, frankly, for the last 100 years. These are the things that we want. We want savings, we want cost control, we want quality, we want range of benefits, and that's what you're going to get with single payer. Next slide. Next slide. So, you know, very simply put, you know, how do we know it can be done? I mentioned earlier, every other, you know, civilized, developed, industrialized, whatever word you want to use, rich country has done it. Not necessarily like single payer. I happen to think that single payer is an excellent way to do it. You know, France, you know, has these private plans, but you know, they're heavily regulated, which is why it works. And yes, they can compete, but they don't compete on you know, this sort of the higher the profit margin. So by denying care, they compete by giving, you know, benefits like, you know, access to gym, things like this. You know, so there are other ways to do it. But, you know, I have spent some time looking at other models around the world, and I hope one day to practice in some of these countries too, to get a firsthand feel for it. But, you know, clearly the way we're going to reduce costs is by, having a much more simplified billing system. And billing, whether it's a sexy topic or not for you, it does affect everything that we do. Everything that we do comes back to billing. I once, 2 years ago, visited a community health center providing primary care in Toronto. And primary care in a community health center in Toronto is a place of last resort, as is a community health center here. So very similar populations, in the hallways I heard all the foreign languages I hear where I work. I heard Spanish and Amharic and Arabic and French, et cetera. Beautifully renovated. I had a chance to speak to the physicians there, pulled off from the group that were having a tour of the health center. And I wanted to talk to an actual doctor while I was there. I asked him, I said, what's it like, working here? How many patients do you see a day, et cetera? So, he told me, and, he was pretty, just frank about it. And, I said, well, how many patients do you see a day? And he said, well, somewhere around like 12 to 16 a day. And I'm thinking, I have to see on my schedule, I've got, booked on my schedule at least 12 or 11 or 12 per session. So that's 24, up to 24, 26, sometimes higher than that when you have the walk-ins per day. So a lot more patients I have to see. A lot of stresses. They have a very multidisciplinary team. They have, a lot of mental health, a lot of support services, which we're struggling to find here in our community health centers. And my last question was, how much time do you spend billing? Like, how much time do you spend just doing the coding? And, he, in his very Canadian way, sort of, crinkled his eyebrows and said, coding, billing? Physicians don't do coding and billing. We provide care. And that was, good for me to hear that because, you read and you listen to the experts, but you want to hear it. Is that really true? Like, what is it like to practice there? And it was a good experience for me to actually see that. So going back to, can it really be done? As I said, no one's done this and turned back around. There have been some experimentations with more privatization. You see that in Holland, a number of other countries, Australia. And curiously enough, there's been some early survey research to look at, people's opinions about privatizing. And people are unhappy. They don't want to turn the clock back. They don't want to base somebody's access to health care on how much you make and how much you can pay for it. Next slide. So, here we are, and I just wanted to point out that, if you want, these slides I'm sure are available to you. Please visit our website. Everything that I pointed out on here is based on peer-reviewed, published articles or government data, and for other organizations like the OECD. And it's all accessible to you by visiting our website. And please check out the students' work. I have to say, of all of the parts of PNHP, I'm most impressed with. I'm obviously very impressed with our founders, Dr. Himmelstein and Dr. Stephanie Woolhandler, and all of the dozens of physician activists I've met over the years. I am ever more impressed with what the students are doing. Extremely innovative in their tactics to teach other medical students, to bird dog the politicians, to organize, to educate, to hold actions, to hold events across the country. So if you're one of those people and you're inspired by this, get involved. Join SNAP. It's free for students. It doesn't even cost you a dime. So, this is a group of students I am just ever increasingly impressed with. And we've worked closely with AMSA for many, many years, and we will continue to do that. So thank you again for your time. I'm happy to take any questions you all have.
Thank you so much, Dr. Zarr, for that insightful presentation and the personal stories. We do have a few questions lined up, and I understand that we've reached the hour, so thank you, everyone, for still being on the line. Our first question asks about healthcare quality versus spending. So is it the healthcare quality or the payment system that is the issue, the main issue?
So it's a good question that really brings to light the connections between quality, improving quality, at the same time addressing this issue of how do we finance healthcare. And you know, for me, you know, one of the most insightful moments was when I spent some time with the chief financial officer of the Taiwanese healthcare system, which was the most recent country to turn to single payer to provide healthcare to all its, I think it's 40 million population. And what he told me, he gave me examples of what that meant for them in terms of quality. And so, for example, you know, when they went single payer, literally overnight, they could see for the first time all of the billing across the country in one fell swoop at the end of every day. And that's what they did. So they for instance, they looked initially at the emergency room billing, and you know, there's codes, so you can see the codes, and they saw a highly, disproportionately high number of TBIs, or traumatic brain injuries, that were being billed for in the emergency rooms. And so they looked further. This was a clue to them. So they looked further, and what they realized was that they were treating a lot of people who were riding motorized bikes, motorcycles without helmets. And so it prompted them to think, well, okay, what should we do to increase helmet use? This is, you know, public health, right? I mean, this is what you do. You think about population. So Taiwan actually instituted some changes and educated the population about the importance of wearing helmets, provided helmets at low cost, and then passed laws to enforce it. And they could literally watch the number of TBIs and the severity of the TBIs go down over time. Much of the quality research that's done in this country still today is done through Medicare because it gives us a peek into a view into 40 to 50, I forgot what the exact number is, but million Americans who are currently accessing their health care through Medicare. So, by can you imagine having 300 million Americans on the same insurance roll through single payer, and all of the research opportunities that allows us to improve quality? It's absolutely mind-boggling what you can do when you put everybody on the same insurance roll. I hope that helps answer your question about quality and finance.
I think it does. I'll let you know if there's a follow-up. Our next question is in reference to this chart that you showed about physician salaries in Canada versus the United States. So the question is, how does patient load compare between the two countries? Meaning, is there a higher minimum for patients that must be seen in Canada or the United States in a traditional office day?
Yeah. So, I alluded to that earlier in that, when I went to visit this community health center, and I work at a community health center in D.C., and they were very, very similar. Both went through $1 million renovations, a beautiful center, very similar population, low income, of color, low resource, et cetera. I have to see somewhere in the order of 22 to 26 patients a day on average, and my counterpart sees 12 to 16. So the pressures are less for sure, but it's also think about it this way. If you have, so I was at one point just curiously I was like, you know what, I'm just going to interview for jobs in Canada just to see what it's like. I wasn't that serious about moving, but I just wanted to see what's it like, right? Let's explore. Why not? See what my options are. So I did, and what I found most fascinating with the interview process was when it was more like informational interviews. I would go on, you can go online and check and see what's available. And I was looking mostly in Toronto at the time. And, the questions they asked me, were how many days a week do you want to work? How many rooms do you need? These are kind of odd questions. You don't get those kind of questions when you interview for a job here, right? it's probably the most important thing you want to know besides the usual patient stuff is your benefits. Well, as it turns out in Canada, because everybody is on the government insurance plan, that the employer doesn't need to sell you the job based on your health benefits. And you also don't need necessarily to work full-time, part-time, whatever minimum time you have to do to be able to get those health benefits, because you could work 1 day a week and you still have the same insurance. You work 5 days a week. So you decide. Basically, they put it back on me. They say, well, it's whatever you want to do. Like, whatever your capacity is now, however old you are, however much energy you have per day, however many patients you want to see per day, that's what you decide to do. And you give a certain percentage to the practice, right? You share in those costs for the things that to provide paper for the beds and gowns and tongue depressors and pay the electricity bills. That's what you're paying for. You give a percentage of what you make to them, to the group. But other than that, you decide everything else for yourself. So there's this sense of autonomy and freedom of choice, not just for the patients, but for you as a physician. If you go onto our website, you search the website for a physician, and if this person, if you can't find it, just tell me and I'll email it to you. But it's on the website. There's a family physician who was in New York, and she moved to Canada. And if you listen to her testimony, she's now practicing in Canada. I think it's actually in the province where Toronto is. Not in Toronto, but you listen to why she moved. She was so frustrated in not being able to provide care the way she wanted to provide it. And I think she's upstate New York. And she started exploring where else could she work. And so she moved to Canada. And you can read her testimonies of how life has changed for her. It's not perfect, okay? I mean, Canada still has poverty. It still has disparities in income. There's still racism. There's still issues. But one thing she doesn't have to worry about anymore is when she writes that prescription, or she does the referral, that her patients go and get it done. They actually get seen. So it's not just numbers, how many patients do you see a day? That's important. But it's also just a day in, day out, routine. Like, what do you have to do to get your job done every day? And I see an increasing amount of burnout and frustration in my colleagues, especially the younger ones, because of all these barriers that are in our way to providing the care.
That's such a valid point. We have a few more questions coming in. Here's our next one. Does your vision of a single-payer healthcare system include tort reform?
Before I answer that, I am happy to stay on this call as long as you guys need. So it's late here for me, but, so be it. So I'm in no rush, and if this doesn't cost you any more money, it's on me. So don't feel pressured by time. At some point I will be exhausted, and I will tell you. What is my opinion or thoughts about tort reform? Once again, if you look, I'm not a lawyer, but I've talked to plenty, and we have lawyers and attorneys who are colleagues of ours in the activism for single payer. If you look at the reasons why people sue, they're actually quite interesting, and you're more likely to get sued when your patient doesn't know you, when they're less familiar with you. They're less likely to be forgiving of a mistake that happened, or when they don't know you. And in our current system, without single payer, your patients are less likely to be able to keep seeing you because of the change in insurance. So nobody really has the same insurance throughout their entire life. And even in your wherever you work, we've had, even where I've worked for 15 years, we've had many, many different insurance plans every year offered to us. So, and that limits the scope of where you can get seen. So I have continuity broken up every year. In other words, I have patients who, let's say they go from D.C. to Maryland, just literally across the border. D.C. is small, by the way. It's 7 miles, wide. So it's not a very, not a very huge distance they move. But then suddenly they have, insurance in Maryland or Virginia, and we can't take that. So that they stop seeing me. So the continuity is broken. So I'm losing patients every year because of this lack of having single payer.
And they're more likely, if a mistake happens, to be less forgiving when that happens. Now, when the mistake happens and somebody gets injured and they have a case, a lot of the suit is to cover the money that they're actually suing for, is to cover the cost, the medical costs to them that they're going to now have to pay to get whatever happened fixed, right? So let's say if you amputated the wrong leg, okay, for a diabetic, for example, well, now you're going to have issues of still operating on the other leg that need to be amputated on, but then now you think about prostheses on both, and it gets complicated. And these are medical costs to that patient, right? So a lot of the costs of that suit have to do with trying to fix or mitigate the mistake that was made. Well, guess what? In Canada, for example, you can't sue for that because everybody has insurance, right? So this is something really important for us to remember, is that in a single-payer system, by its very nature, single-payer's very nature, the issue of tort reform, it doesn't go away entirely, but it's significantly decreased. I will also tell you that a place where I work at a federally qualified health center. My malpractice is covered by my work entirely, and my work's malpractice is covered by federal tort. So it's exceedingly difficult to sue the federal government. So, for folks like us, who are dealing with very high-risk populations, with lots of turnover, both in the patients and in the doctors, we feel quite protected. So I don't pay for my own malpractice. And so you can imagine a system in which we have, the federal government covering us in this way, which it should, right? I mean, I think that's an important role to play. I hope that helps answer some of your concerns about federal tort.
All right, next question. What, if any, role does racial, ethnic diversity in the U.S. play in our unwillingness to go to a single-payer model? Are the other countries in the comparisons more homogenous?
Well, it's a good question. We do live in a ethnically and racially diverse country. And, this is brought up a lot, as we try to compare the U.S. and other countries. And I think it's to our detriment, that we think we're so different and we're so special and we're so complicated and we're so big that we can never do this. And I go back to my own personal experience when I travel the world. Even as close as just Toronto. I always went to Montreal. You see a population that is as diverse as it is here. When I walk through those halls of that community health center, I'm seeing, and hearing exactly what I see and hear right here in D.C., which is a very, very diverse community. So if anything, we should be so concerned that when you look at these, the diversity, which we all want to celebrate diversity, but we also need to understand that it's these people of color, people who are living in economically desperate communities, who are the ones who would most benefit from this in the first place. Now, having said that, there's good data, good evidence to show that even the middle class and wealthy would benefit from single payer, not just the poor, not just people who are living in communities of color. When a large segment of the population improves, everybody improves. And I go back to public health with this. People in this country who are in high income brackets, who have maids come and clean their homes, who have, people who cook for them, people who build their roads, who clean, the buildings. These are my patients. And when my patients get sick with tuberculosis, a communicable disease, they pass that on to us, And so if you think about it from a public health perspective, everybody is to gain when we have single payer, not just the poorest and communities and the communities of color. in this country. So, I don't think I don't think that we can say that, oh, well, the Netherlands or, Sweden has single payer because they're small and they have a homogeneous population. I don't think that's fair. I think there's plenty of countries around the world where they have just as diverse a population, and they have come to the same conclusion that we have come to, that it is possible. I think a more important question for me is where we're going to find the political will to make this happen in this country. Certainly right now we have, complete, an impasse. It's hard for me to imagine in our current Congress getting a bill like single payer, H.R. 673 to become 676 to become law. But I was very encouraged this year when I saw Senator Sanders run his campaign on single payer as one of the most important issues to him, and the kind of popular support for single payer and for him promoting single payer that I have never seen before. So I'm actually really encouraged, despite where we're ending up now, between well, we have more than two candidates, but there is Jill Stein, by the way, with the Green Party, who's single payer is part of her platform. But realistically, the two candidates right now, we don't have single payer in the forefront. But I think it's a really interesting time with, Black Lives Matter, with Occupy, with this growing interest in activism, especially in young people, but not only in young people, but especially in younger people, and who've come to this conclusion that many of us have come to, that we cannot keep going down the same path. It's a path to implosion, which is what we're seeing now.
All right, and our last question for the evening: why aren't employers in the U.S. more active about wanting to get out of the healthcare benefits business?
Well, part of what we see going on here is just inertia, right? People just do what they're used to doing, and it's not out of malice. It's not out of sometimes it's not out of even not knowing what's right to do, but it's just what's done and what's presented to them. And so what we see happening in many employers, including my own, it's cost shifting. It's removing, it's whittling down your policies because it's what's being offered to them, right? There just isn't a lot that's great that's ever offered, to the employers to offer to the employees. And what's been happening is the cost shifting to the patients, to the consumers of care. So healthcare is becoming less and less affordable. And, it does make sense to get business on board, big business, small business. There's a movie, if you haven't seen it, and it's excellent. It's called Fix It. And the movie was produced by the CEO of a picture frame company in this country. He's a wealthy man. And he has come to his own conclusion that single payer is the only solution for his company and for every company in this country. And he makes a really good business case for it. And we promote his film because, a lot of his film is interviews of, our single payer activists, but of others just making the case for it from a business mind. So, there's no doubt that that's the route that business needs to go. And I would say that people like him are showing us that there needs to be inroads made into many different segments of our country. We already have a lot of connections with the labor movement, with faith-based groups, with other advocacy groups in the country. So, we're definitely growing in terms of our base, and we're creating these relationships that are really going to help us to reach new audiences. So I think it's a great question. I think, once again, the answer probably more lies in the fact of, things continue in, in the way they've been done, because that's just the way things are done. They don't have to be done that way. And I would encourage you, even where you are now, in your academic institution, bring this up. Bring this up with your faculty. We have a number of students around the country who are literally writing their own curriculum for, courses that teach their peers, the basics about health policy. And these are things that you all can do in your academic settings, so that it becomes a much more institutionalized part of your education to talk about this and learn about this.
All right, thank you so much, Dr. Zarr, and thank you everyone again for participating. Please join us tomorrow tomorrow evening for another webinar. We will be discussing mental health and physician burnout in primary care. Thank you again, everyone, for attending, and have a good night.
My pleasure. Good night, everybody.